Very cool, guys. All right, so I'm going to go through these slides, and at the end, if anyone has any questions, uh, we'll hold those to the end if you guys are okay with that. Um, so, so basically, before we get going here, so what we're going to focus on today is we're going to talk about peptides for a little bit and how you can integrate those in your practice. And then we're also going to go over some of the other regenerative like PRP, A2M, ozone, and some of those. We'll kind of touch real lightly on all of them so you guys have a base understanding. And then if you have any other questions at any point, obviously Dr. Santa has my contact information and he actually knows a lot of information himself. So feel free to reach out to me or Dr. Santa for further clarification or if you need research or whatever you need to feel comfortable with the procedures. So, I want to start off with I'm a chiropractor by trade. I've been in practice since 2000. Been medically integrated since about 2006 and have been doing regen medicine for the past 13 years. So I kind of got in at the very beginning, started out using, back then we were just using amniotic membrane and PRP. But obviously the technology has evolved and now we have a lot better tools. We have peptides, we have A2M, we have Wharton's jelly. And the field is constantly progressing. So there's more and more good stuff coming out all the time, and we try to stay on top of it. And I would say my patients and actually my pets are the guinea pigs. So I have 14 offices, so we do all these. Usually, what we'll do is we'll roll stuff out on my patients first, and we get good results. Then we make them available to everybody else. So everything we'll talk about today, I've had a lot of experience and I've treated, hundreds, if not thousands of patients with these protocols. And at the end, I'll also go over some of the programs we put together, so you can kind of see how we package all this stuff together. But I really feel like, obviously we have a stem cell lab, a peptide lab, we make PRP and HMO kits. And we sell not only to chiropractors, but to orthopedists, to wound doctors, to lots of other doctors. But I always feel like chiropractors do it the best because these other provider types, when they go through medical school, they're not that they're indoctrinated, but they are always looking for, to treat the symptom and not get to the root cause. And why I think chiropractors do so good with regenerative medicine is regenerative medicine really focuses on getting body to heal yourself, and that's something that really all chiropractors kind of get. So, that seems like these fit into chiropractic offices or offices that are managed or run by chiropractors really well. Because with all of these procedures or therapies we're going to talk about today, the focus is just getting, helping your body heal itself. And that's what we believe as chiropractors. I'm going to start off, we're going to go over peptides first. Basically what are peptides? I'm sure everyone here has heard of peptides, but to be very clear what they are, they're just small chains of amino acids, which means they're 50 amino acids or less. Once you get above 50 amino acids, then it becomes a protein. But the key concept is they're just signaling molecules. And basically what's cool about them is there's specific short instructions, kind of like a text message to tell your cells what to do. So a good example would be insulin's a peptide. So when you eat a bunch of sugar, your body wants to get the sugar out of the bloodstream and into the cells, so it secretes the peptide insulin, which tells your cells to, suck up, get the sugar out of your blood. And the other cool thing about peptides is it doesn't really signal anything else. So they're very specific in what they do. So they target just what you want them to do without messing up with everything else. There's hundreds of peptides out there. We don't have time to go through all of them, but what I do want to go over today is the ones that you can use in your practice today that are very effective. And these are the main ones we use in our practices too. The first peptide I'll talk about is BPC-157. BPC-157 is very important for healing because it does several things. Number one, it promotes angiogenesis. If you think about these areas that you treat on people that don't heal, knees, shoulders, tendinopathies, those are all areas that over time don't have good circulation. So anytime you can promote angiogenesis and improve circulation, you're going to help the healing process. They also modulate cytokines, which are the proteins that cause pain. So, you know, although I'm not super concerned about pain, it is good for patient satisfaction because when you use BPC-157, it helps significantly decrease the pain without using like an NSAID or a steroid or something that's going to be catabolic to the area. You're actually, it's an anabolic agent, but it also modulates these cytokines. And then the final thing that it does that I don't discuss with patients a lot, but I do feel as though is very important for a lot of our sick patients, is BPC 157 helps heal leaky guts by sealing the tight junctions. And a lot of the patients you treat, fibromyalgia or have pain everywhere, a lot of that is due to leaky gut because most people aren't healthy and have leaky gut, and leaky gut leads to systemic inflammation. And BPC does a really good job of healing those tight junctions, thus reducing leaky gut, thus reducing systemic inflammation. So that's why it's such a powerful peptide.
So is it a good indication just for uh, general overall pain, things like that?
Yeah, anyone with fibromyalgia,
Fibromyalgia, right?
yeah, or sometimes, I mean, Dr. Dean, you have people come in like everything hurts on them, like my knee,
Yeah.
my back, everything. Like so, and unless you're going to go down the functional medicine rabbit hole and like really fix their gut, fix their
Oh,
adrenals, I mean, which you can do, but that's months, months of time and it can be expensive. BPC is a shortcut because no matter what they got going on in their gut, it's going to help heal those tight junctions,
how
thus
about
reducing that systemic inflammation. And it's also very effective. Anyone with colitis, Crohn's
that was
disease,
my next question. Yeah,
IBS, it's a miracle for those things. It's
that
very,
was my
very,
next question. Good.
yeah. So because it takes down that inflammation. The next peptide we'll talk about is GHKCU. It's a copper peptide. A lot of people like to use it as a topical to put on their face or for hair growth because it enhances collagen production, and it also reduces oxidative stress. So when you can get that into a joint area, I mean, if you think about it, these areas we're trying to treat usually have poor collagen or the collagen has been degraded by proteases like, that cause arthritis. Anything you can do to help the body produce more collagen is going to be helpful in that healing process. You have NAD plus, which boosts mitochondrial function. Obviously, the mitochondria is how your cell, basically, it's the coenzyme that makes your cells work. So, and but the downside is by the time you're 40, you have about half of what you had when you were younger, and it decreases about 10% a decade after that. Thus, your metabolism slows down, your ability to heal slows down. That it's all negative. By taking NAD, it boosts mitochondrial function, which shows subjectively in people. And I've had people, last time we were at one of the coaching events, someone put a BPC patch on or an NAD patch on, and I don't prescribe NAD specifically for pain. I usually would say BPC probably more appropriate, although a lot of these peptides there's overlap. And I had a guy that had chronic back pain came the next day and say, "Hey, man, I don't know what that patch was. I don't have any more energy, but my back doesn't hurt today." So obviously, this guy had some type of mitochondrial dysfunction in his back that was causing his back pain. So, but I will tell you of all the peptides, NAD is the one that you'll feel the most if you're healthy because it boosts energy, definitely clears brain fog. Like I said, it's not like Adderall, but it just gives you more energy, but it also helps your circadian rhythm and helps sleep too. So, yeah, I mean, that's probably my favorite peptide for healthy people. Also very effective for anyone that has TBIs or concussions. We actually have a paper we're going to get published real soon where we're using a combination of NAD and KPV, and we tested CRP levels on people, and they dramatically decreased after a few days. And I think, Dr. Dean, didn't you have a patient too that had CRP was elevated? And I think you used BPC and NAD.
No, we used the KPV on an NAD on him, but he did really, really well. He was the one with the systemic. I can't remember the term for it, but basically, it's just he was on high doses of prednisone. He had a systemic, yeah, and he did very, very, very well with it, and drastically reduced. In fact, he's off all his prednisones, and he's 83 years old. He's heading off to Alaska for a photography trip 2 weeks from now. So,
Oh,
thanks.
that's awesome. Yeah, and
Brilliant.
I'll
Yeah,
go into like and I'll go into the KPV more in a little bit.
yeah.
The main thing with KPV is you have the nuclear factor kappa gene that in people with autoimmune conditions, that nuclear factor kappa is basically, I want you to think of that as an inflammatory switch, and it turns on all the inflammatory cytokines. KPV shuts that switch off. So people that have chronic autoimmune conditions and you put them on KPV, it's a life changer because it literally shuts down the body attacking itself. So it's a very powerful peptide. And then the final one we'll talk about is glutathione. And glutathione is basically the body's master antioxidant. Anyone who has oxidative stress, which is probably everybody, would benefit from taking glutathione because it really helps, neutralize reactive oxygen species and free radicals, thus preventing oxidative damage, DNA damage. And these are all peptides that even, and you don't, to be clear, you don't need to have a medical provider to use any of these peptides. Okay. Now, if you're injecting them, you do, but we'll talk about some other ways that you can use them in your practice without integrating medical, if you don't have medical
Mhm.
experience. And the way we like to do it is with iontophoresis. Iontophoresis is basically uses electric energy to push molecules directly through the dermis and into the bloodstream. It's been around since the early 1900s, but obviously the technology's changed. I can remember when I first started practicing, we were using iontophoresis, and it was like a big TENS unit with wires. And I think we were using lidocaine or something. I don't even remember. And it would help a little bit, but it was big and bulky. You wouldn't want to wear it. We've actually developed a self-contained patch that looks kind of like a piece of kinesio tape with a membrane. So you can just wear it. There's no wires. It has its own battery, its own microprocessor. So very convenient to wear. That device is prescription only, but chiropractors can prescribe it. So once again, you don't need to have this touch your medical staff, or if you don't have medical staff, you don't need to go hire a nurse practitioner or PA. This is something that chiropractors can do, but your patients can't go on Amazon or eBay and buy these because they are prescription devices. And what they do is they allow a controlled release of these different peptides over 12 to 14 hours. And there's several advantages of that because it's going to give you more steady blood levels, and it's also easier for patients to use because they're not most people don't like giving themselves injections. But when you look at these peptides, remember that we said they're just short chains of amino acids. Because of that, their half-lives are very short, and they also don't do well when you take them orally. Like BPC half-life 3 to 4 hours. So I was mentioning my dog I'm using BPC on, and he's hairy, so I can't put a patch on him. So I'm injecting him, but I'm injecting him twice a day. NAD half-life's an hour or two, glutathione 10 to 15 minutes, GHKCU 30 minutes, KPV 30 minutes. So you can see if, injections do work for these. You can't take these orally. The absorption rate is very, very low. You can inject them, but you are relegated to injecting multiple times a day to get the maximum benefit if you're not going to use iontophoresis. And really, to understand what we're talking about here, you're talking about the area under the curve, and that's a common term used in pharmacology. And the area under curve basically means, the easiest way to think of it is if you have a bathtub and we'll say you have a leaky bathtub. When you use something with a short half-life, it's like you have a high pressure hose and you're blasting a bunch in there, but it's going to drain out really quickly. So you really don't have water in the tub that long. Where when you use iontophoresis, it'd be like leaving the faucet on slow so it doesn't leak out as fast. So it keeps the water level higher for longer. So it's just better than using any type of medication that has a short half-life. Now, there's some things that wouldn't make sense. Like you look like a GLP-1, like the weight loss medications, those half-lives are 5 to 7 days. So it kind of wouldn't make sense to use a patch for that because you can just inject it once a week. Or even testosterone, the half-life's about 3 days. So, if you don't mind giving yourself a shot every 3 days, it wouldn't make sense. But with these peptides in particular, iontophoresis is a much better way to get the medication and have the cellular effects because you're going to get that slow delivery of the molecule over 12 to 14 hours. And that's going to ensure you get maximum cellular absorption. It's going to prolong the biological effect. And most importantly, it's good. The healing, regeneration, and anti-inflammatory action is going to be much better than doing an injection. So, and we got to keep in mind here, with regenerative medicine, we're not just treating the symptoms, we're trying to restore function and reverse disease. So that really requires sustained cellular signaling. And that only happens, remember, these are signaling molecules. That only happens if the molecules stay in that area for a prolonged period of time. So the longer the sustained delivery, the better the healing process. Now I'm going to kind of skip out of peptides and we're going to go to some of the other regenerative procedures. Now, these procedures here would require medical staff to do because these are all going to be injections. But I did want to kind of clarify because there's a lot of misconception. A lot of people don't know what A2M is. They think all PRP is the same. What is ozone therapy? What's the difference between the exosomes and we'll say like a Wharton's jelly or umbilical cord tissue. So if you look at this chart I have here, I've kind of categorized them, and I put A2M at the top because A2M functions totally different than everything else here because A2M itself is not anabolic, but it's the only thing here that stops arthritis at the molecular level because it stops the cause of arthritis. Nothing else here stops the cause of it. This actually stops the cause of arthritis. I'm going to go into more detail as I go through these slides, guys.
Buzz, are these slides going to be available to us?
Yep, I'll give them to Mark
Good. All right.
or
Thanks. Thanks.
Debbie. Give it to
Yeah.
Debbie if
Yeah.
you guys want to
Thanks.
get
All right.
it
Thanks.
right. Ozone therapy, double spin, exosomes, and Wharton's jelly. So I'm going to go through all those so you guys are clear. So let's talk about A2M first, which is alpha 2 macroglobulin. And basically, just to be clear, A2M is a protein that's circulating in your venous system. It's actually the largest circulating protein in your venous system, which means we make it out of the person's blood. And I'm going to be making it out of my dog's blood, I think, too. All animals have it. Horses, we treat a bunch of horses with it. So all animals do have this A2M protein. It's in their venous system. But the issue is that it's so large, it can't get into your joints. But what we know about A2M is a broad-based protease inhibitor. And no matter what type of arthritis you have, osteoarthritis, psoriatic arthritis, degenerative joint disease, all arthritises are caused by proteases, which are proteins your body releases either due to an autoimmune response, trauma, post-surgery, and those are designed or they're released into the joint to clear damage out of the joint. So they're like little termites in there. The problem, though, is as we get older, our joints become avascular, and these proteases are large proteins and they get trapped in the joint. So when those termites are trapped in the joint and they can't get out and there's nothing left to clean, they start to eat away at the synovial fluid and cartilage, thus causing arthritis. So this is the cause. A2M is the only way that you can stop that. Look at these are like bug spray for termites. So when the analogy I always use with people is if you have a garden and you have these pretty flowers and all of a sudden a bunch of beetles eating your flowers, you have to decide, what am I going to do? Well, you could put more fertilizer in the garden, and that's what, like using PRP or Wharton's jelly or exosomes, you're putting something anabolic in there to try to outgrow the catabolic effect of the beetles. But if you don't get rid of the beetles, no matter what, long term, they're going to come back. So if you really want to stop arthritis and have a more permanent cure, you got to get rid of the proteases because they're not going to go away on their own. And A2M is the way you do it. And it's pretty simple to do. You take a person's blood, you spin it down, you run it through a filter, you capture it, and then use a needle to put it into the joint. The other cool thing about A2M is it also does a really good job of inhibiting cytokines, which cause pain. So most people get pretty significant pain relief fairly quickly,
Yeah.
depending on how many cytokines they have. And obviously, that helps promote cartilage preservation and degeneration in your arthritic joints. So, anyone that does arthritis, in my opinion, has to do A2M to have more permanent results. Ozone. So, now the order I'm going to go here, these are all going to be anabolic agents, and I'm going to go weakest to strongest. So ozone is the weakest, but that doesn't mean there's not value to it because ozone is very powerful. And I like to explain ozone, it's kind of like CPR for your tissues. Because once again, kind of going back to what we
CPR
talked
for
about
yours.
earlier, these areas that don't heal typically have poor circulation. They don't have good oxygen, and your own stem cells need oxygen to produce the growth factors, or if you put stem cells in there or whatever you're doing. So, although you can't inject oxygen, or you shouldn't because there's nitrogen, you can get embolisms. Ozone, which is O3, is even more powerful because it's three oxygen molecules instead of two. And what that's going to do is it works on several different mechanisms. It's going to increase antioxidants, it upregulates glutathione, it modulates cytokines. Once again, it enhances oxygen delivery to the cells, promoting ATP production and mitochondrial function. Because don't sleep on mitochondrial function. People that have injuries that don't heal have mitochondrial dysfunction. So anything you can do to help the mitochondria and increase circulation, that's why BPC and NAD are good too. You want to get those cells healthier so they can heal. Because at the end of the day, when someone's not healing, they're more catabolic than anabolic. It's our job to reverse that process. It also promotes microcirculation and angiogenesis by stimulating NO production. And it also inhibits antimicrobial effects. That's also beneficial, especially if you have healing wounds or like diabetic neuropathies. We use a lot on also. And it's pretty simple. The ozone injections, you get have an ozone generator. You have an oxygen tank hooked up to it. You turn the generator on. It literally fills up a syringe with ozone. It looks like air, and you're injecting that air into the area. I mean, remember, it's not oxygen, it's ozone. PRP. So, um, just to be clear, there's two different types of PRP. There's single spin PRP and double spin PRP. Um, there's no clinical evidence that shows single PRP is any better than placebo anywhere. You won't find a study. So, if you've done PRP and it didn't work out, or you're using PRP and it's single spin and you're not getting good results, it's because the clinical evidence would show single spin PRP is just not concentrated enough to cause any anabolic effect. So, if you're going to use PRP, you really have to use double spin PRP. And that requires you to take the person's blood, spin it one time, take the buffy coat, and then spin it a second time, because that's the only way you can get to 9 to 12x baseline of your platelets. And you also need a certain amount of blood. You need about 60 mLs of blood to get the platelet count you need. So there's no PRP kit out there where you can pull 10 or 20 mLs of blood and expect to get something concentrated enough, because there's only so many platelets per ml of blood. And you can't get there spinning one tube of blood. So it does require more blood. I would say at least 60 mLs of blood is kind of what the research shows to get to that 9 to 12 baseline. What PRP does, it has multiple growth factors to promote tissue repair. It reduces inflammation. Um, and as you can kind of see here, single spin PRP, that which if you're wondering whether using single spin or double spin, do you spin it once or do you spin it twice? The problem with single spin is you're really only concentrating the platelets 1.3 to 1.7. So by definition, that's platelet poor plasma. PRP by definition is at least 3x concentration, but you have to double spin it to get there.
It starts with a little bit of cake, so no iron information, but this type of sugar.
Some other things to consider when making PRP, the speed at which you draw the blood out matters. If people are using regular blood collection tubes, those usually pull the blood really hard, and that can cause the platelets to shear. And you don't want to damage the platelets before you use them, because that's where all the good stuff's at. But if using a blood collection tube, that mechanical stress causes degranulation of a lot of the growth factors, which you don't want. It also can cause hemolysis, which, if anything, causes PRP to hurt worse. And I can't tell you how many patients we've had come in and we'll say we want to do PRP, and like, oh man, I did it before, that really hurt. Well, it's either because they were using tubes where they're probably drawing the blood too fast, which caused the release of inflammatory cytokines, or there was a bunch of white blood cells in there. They didn't filter the white blood cells out, because PRP should never hurt. There's nothing in there that would hurt, but if you damage the platelets or if you have a lot of white blood cells, it's going to hurt like hell the next day. And you don't want that. You don't want more inflammation. You also want to make sure that you're not using sodium heparin in your tubes. Um, the same type of thing here. Basically, it damages the platelets, and it also changes the pH, which could cause destabilization of the membrane. So you just don't get the same amount of growth factors. And then the final thing I really promote is you want to filter out the white blood cells. White blood cells, you can't filter those out by just putting in a centrifuge. You have to run it through a filter. Because white blood cells have the same exact molecular weight of platelets. So if you think you can just spin it and get the white blood cells out, that won't work out, because they're going to be stuck with the platelets. So really, when you get done making your double spin, you should push it through a filter that filters out the white blood cells, and that will ensure that you're not going to get any extra inflammation after the procedure's done. Because remember, at the end of the day, PRP should never hurt. And PRP, good double spin PRP is very powerful. Exosomes, so exosomes are derived most commonly from umbilical cord tissue, and they're very small molecules. They work very similar to peptides if you really think about it, because they're just cellular communication cells. They do a really good job of promoting anti-inflammation, which helps with pain. They also can stimulate tissue regeneration, enhance collagen synthesis, and reduce fibrosis. And they also help modulate immune response. So, although I would say in younger people, I'd say 30 and below, I would probably prefer a double spin PRP. The birth tissue stuff, the exosomes, warts, jelly really starts to stand out as people get older. We'll say, 30, 35, 40, or if they're younger and unhealthy, metabolic syndrome, smoke, all these different things. So when patients come in, I'm trying to decide whether I want to use PRP, or exosomes or Wharton's jelly. I kind of look at the age of it. A high school athlete, double spin PRP most of the time is what I'm going to use. 45-year-old diabetic, I'm going to go to birth tissue. So those are kind of the things that I use in my practice. And we sell a bunch of exosomes. I don't use a lot of exosomes because um, I prefer to use Wharton's jelly. And the reason I prefer Wharton's jelly is Wharton's jelly already has billions of exosomes in it, but it also has lots of things that exosomes don't have. So you have long chain hyaluronic acid. You have other growth factors that you won't find in exosomes. It doesn't mean exosomes don't work. It's just you get more with Wharton's jelly, in my opinion, than you do with exosomes. So, and anyone that's used both, they both work. So I'm not talking bad about exosomes, and we probably sell as many exosomes as we do Wharton's jelly, and some people love them, and there's nothing wrong with it. But if you really look at the science, there's more proteins and there's hyaluronic acid, which I think for orthopedic use makes a lot of sense by using Wharton's jelly in comparison to exosomes. I think exosomes make a lot of sense if you're doing an aesthetics practice, you're using microneedling. If you want to get past the blood-brain barrier, exosomes do that much easier. You'll get a higher percentage past the blood-brain barrier with exosomes. But if you're treating joints, neuropathies, things like that, I prefer Wharton's jelly. That's just my personal opinion.
So Buzz, on the differential, indications for exosome versus Wharton's jelly IV, all right?
Mhm.
Would you say the exosomes would be more appropriate for somebody like with Parkinson's disease or post-stroke or something like that?
I can tell you that we've had our most profound results using the ESC product.
What's
So
ESC? That's
yeah,
Wharton's jelly?
yeah, and that's Wharton's jelly derived. That doesn't mean exosomes wouldn't work, but I've had multiple people that were in wheelchairs, like really messed up, and like you wouldn't believe what happens. Kind of like
With
your CP person.
with neurological,
Correct. But
right?
that doesn't mean exosomes wouldn't work. Like there's a lot of overlap in these things,
But you
and
would
like
still but you would still prefer IV Wharton's for that, right?
me personally, yes.
IV
Now, there's
Wharton.
lots
Okay.
of providers that would probably disagree with me on that. As I
Mhm.
said, we sell a lot of exosomes, so I don't want to downplay exosomes because I have some people that love exosomes.
Okay.
I've kind of always used Wharton's jelly and I've had really good luck
Uh,
with it, so that's where I've stayed.
that
Um,
answered my question. That's exactly
yeah,
what
and I don't have a big enough database of my own patients to say one's better than the other because I just the one works and I don't want to switch. And then the final thing I want to go over, if you're doing any type of injectables, you really have to start using scaffolding. Because what you have to keep in mind, whether you're injecting A2M, PRP, Wharton's jelly, exosomes in liquid form, when you inject a liquid, it's only going to last in that area for a few hours to maybe a day or two at max, because it's liquid. Now, scaffolding, which there's a couple different ways you can get it, is more of a gel. So this example here, this one here is we as Wharton's jelly scaffolding mixed with Wharton's jelly. But when you inject this into an area, it will last several months. So you're going to get more of a time release result. Kind of like like going back to the iontophoresis, the area under the curve is going to be much better when you're injecting a scaffolding. And there's a couple ways you can make scaffolding. When you're making PRP and A2M, my recommendation is you're going to have leftover platelet poor plasma anyways. Just take that platelet poor plasma, which you're going to throw in the trash, you put it into a heater. That'll change the conformation of the protein and make a gel. And then when you get done with your final A2M prep or PRP prep, the kits come with connectors. Just connect it to the scaffolding you made in the heater, mix them back and forth 20 times, and inject that. You're going to get much better results. If you're using exosomes or Wharton's jelly, we do sell it's basically a scaffolding that's derived from Wharton's jelly that you would mix one for one, and it's just going to improve your results. And a lot of people say, well, can we use PRF or hyaluronic acid? The problem with PRF is it degrades really quickly, typically within 1 to 2 weeks, where the scaffolding you make from platelet poor plasma or Wharton's jelly will last several months. And it really lacks the structural ECM necessary for durable tissue support. So I'm not a big fan of PRF. And hyaluronic acid, although it comes out thick, its primary function is it's a lubricant and it breaks down pretty quickly. So it's still not going to work the same as taking your platelet poor plasma, which is free if you're making A2M and PRP, or the scaffolding from Wharton's jelly, which is it's going to be less expensive too. I think it's like $100. It's just those are just better vehicles to bind with whatever else you're using, PRP, A2M, Wharton's jelly, exosomes, and hold it in that area and provide a matrix or a scaffolding so they stay there and they work over time. And that also prevents you from having to do multiple procedures. Because I know back, I mean, people still do it now. Like if you treat neuropathy, they have you come for a neuropathy PRP injection every 2 weeks. Well, that makes sense if you don't use scaffolding because it's clearing out of there probably within a day. But if you would do the same thing but use scaffolding, you wouldn't have to do multiple procedures. I'm going to kind of go through some different procedures we do here. Like here's an example of a joint rejuvenation package at our office. So if someone has arthritis, we always do A2M first. So we do A2M and with bioscaffolding. So we just make the scaffolding once again with the platelet poor plasma that's left over, so that doesn't cost us anything. And then what we do 6 weeks later, I let the A2M sit in that joint and kind of work away and clear all the proteases out. But that takes time. So you can't do A2M with umbilical cord at the same time. They would, because basically what would happen is the growth factors in the umbilical cord would compete and take up a lot of the binding side. So when you put A2M in a joint for arthritis, you want that to sit in there for 4 to 6 weeks and let it just clean the joint out. And then, basically we get rid of what's catabolic, and then we're going to put something anabolic in there, which is umbilical cord allograft with scaffolding, and that's going to help the tissue grow back faster. If someone has a lot of systemic inflammation, that's where we use the ESC IV product, where we do an IV. I usually do that right in the beginning to get that inflammation down. In the middle of those 6 weeks, we'll do 2 ozone injections. What does that do? Once again, we're preparing the joint for the stem cells. We're modulating cytokines. We're getting some angiogenesis in there. I also having run BPC and NAD iontophoresis patches. I just have them wear twice a week. If you have a person wear 2 of the BPC patches a week, they get 200% more BPC than if they were injecting daily, just wearing 2 patches a week when you look at the area under the curve. This is our rehab program we do here. And the value, and then that's what if they pay in full, that's the discount. That's what we charge in our facilities.
I have a question.
Yeah.
With the A2M, what's holding the A2M in the joint? Maybe you had mentioned it, but are you using scaffolding with the A2M as well?
For sure, yeah, because what's going to happen, included in that kit, you have everything you need to make the scaffolding. So because you have a lot of leftover platelet poor plasma, so what I would you take some of that platelet poor plasma, throw it in the heater, and while you're running the A2M through the filter to make the A2M, let that stuff cook. And by the time you're done with the filter, that'll be ready to roll. And then you just mix them together.
Okay.
Yeah, but for sure you want to use scaffolding with A2M. You really want to use it with anything in our practices.
You're talking about scaffolding as well. I know my friend did my dad's knee before I hooked up with Mark, and I surf with him. He's Javid Pierce. I believe you know him. He's with Clot Master, and he has a scaffolding product that he feels is one of the best ones out there when you add it with Wharton's. And that's what we did with my dad's knee with the Wharton's, and he's the one who developed the FDA approved scaffolding. I don't know if you're familiar with Clot Master.
No, I'm not. What is it?
Pierce Orthopedics. You can check it out. He's a friend of mine, and
I think I know what that is. That is
Javid Pierce.
I think that's this play. I think it's the same thing that you're going to be able to make for free. That's a play. I think they use it for wounds, right?
Wounds, but also with joint regenerative procedures like you're talking about as well.
Yeah, they had that centrifuge that spins really quick. I've seen the unit.
And no, it's a slow one. It actually has like a little hula thing, and the blood. It's a timing thing where you inject it into the joint first, and then you follow up with Wharton's. and it creates like, it's really cool. It creates like a little pad and cushion, and apparently he feels that that helps hold the stem
Is it
cells.
made from, is it made from blood?
Yes.
Yeah, so it's probably something similar. They're changing the conformation of the protein, but you're going to have in your kits the ability to make that for free. So I don't know that it would make sense to go buy a separate unit, because once you change the conformation of the protein, that's very robust. That lasts several months.
Okay.
So, and you're going to have, otherwise you're throwing it in the trash anyways, kind of thing. You know what I'm saying? So you might as well just take what you already have there, part of the same procedure. It literally takes you another 30 seconds to throw that thing in the heater. And there's a connector too, so it's a fully sealed system. So you just use the connector, connect the scaffolding when you pull out of the heater to whatever your prep is, A2M or PRP, and just mix them back and forth, and you're good to go. And
All
it'll
right.
look just like that diagram I showed you there. It comes out as a gel. Should push through a 27 gauge needle if you push, or a 25 gauge, no problem.
Okay, thanks.
Yep. The spinal decompression packages, this is kind of how we do it. You know, spinal decompression, we do umbilical cord injections with that. Once again, if they're really bad, we do IV. Anyone has a decompression practice, the BPC, NAD, GHKCU patches are amazing. You put them right on their back. I really like it, especially a lot of people in decompression practices come in with really hot backs and you have a hard time using decompression sometimes in the beginning. If you put the patch on for 2 or 3 days in a row, you'll get them out of that acute phase so you can get a better pull with your decompression.
And Buzz, these allograft injections, these are paraspinal injections.
So you can do paraspinal. I prefer to do intraspinous, but I would say a lot of physicians are doing paraspinal.
So
And
you're
then,
just doing an injection just between the spinous processes then?
yeah, make sure you get trained on that though.
Yes, right.
Yeah, you don't want to mess that one up.
No, no,
But
no, 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 you
that does a
don't.
really good job. I know Dr. Joe Gambardella has a training that he does on it. And it doesn't mean paraspinal doesn't work, but it's kind of like hip
Right.
injections. If you're doing hip injections, anterior approach is better by far. And we've done it both ways. I would say the same thing. Once you get really good at that intraspinous injection, we had pain management, we were doing facet injections and a bunch of other stuff, and intraspinous works just as good. So I really
And
like
it's safer.
intraspinous injection,
And it's safer, right?
as long as you know what you're doing.
Right.
If anyone does neuropathy, the same thing, you definitely want to use scaffolding with neuropathy because in particular that area clears out. I have Tesla there, but there's rebuilders, there's a bunch of other units. I can't recommend Tesla because I think the way they I don't like the way they do business anymore, but that's what we use because we have the units. But something basically with neuropathy, the key is you got to restore circulation. And how do you restore circulation? Well, you might have shockwave, you might have laser, you might have rebuilders, like whatever units you're using, because they all work, right? I think ozone injections are essential for neuropathy, and the allografts also work really good for angiogenesis. So, and then at the end of the day, that's where the BPC NAD also come in because BPC is also going to cause angiogenesis, and you have to do something to get NAD levels up. You know, the reason the nerve dies is decreased circulation decreases NAD in the cell, and that's why the nerves die. So no matter what you're doing, you got to get some NAD to the people. So that's why using the patches makes so much sense. We'll talk about FDA and FTC guidelines. You know, every single thing we talked about today is not FDA approved. And if it is approved, it's not approved for what we're using it for. So when that happens, that means you can't make claims.
Yeah.
So
Okay.
you can't say we're going to use
I understand it's on one of those
PRP for your
websites,
knee,
which
you know, to cure your knee pain, or A2M to cure your arthritis, because you know PRP is approved for bone
I
setting.
looked
You
at
won't
them.
do
Yeah.
bone setting.
They look nice.
Yeah.
I don't
So
know
so just
how.
make sure in your advertisements
much
advertise
difference
the
from
condition
ours,
and
but
people
yeah.
come and go to your
It's just like
toolbox.
the appointment thing.
So
It's like that is.
Same.
and then the other thing that you guys have to watch out for is the FTC.
Like the like.
Hey, John.
Just come in and get.
Hey, John, you on there?
I saw that. Would you send me?
Put yourself on mute.
Yeah, if you can mute yourself. Yeah, thank you,
Sorry.
John.
Well, sorry.
No worries. Okay, cool. The FTC is what you guys have to worry about more, and basically the same thing's going to apply. Anything that you're doing that's not FDA approved, which is everything we talked about today, you can't make claims on. So don't advertise, A2M for arthritis, PRP for hair regrowth. So you can use the terms orthobiologics, joint rejuvenation program, but you do not want to advertise specifically what you're doing for that thing. And at the end of the day, people come in for the condition. So, I've had really good luck. Advertise the condition when they come in, then you go to your toolbox and you tell them what they need. The other thing you got to be clear on is because they're not FDA approved, you have to have patient disclaimer forms signed that clearly state that the products you're using are not FDA approved and there's no guarantees. But as long as you have that in place, there's nothing illegal about using anything we talked about today. It's totally compliant. Where people get in trouble is they don't have consent forms signed, or they're saying they're treating MS with stem cells or curing this or that with these non-approved products. You just can't do it. And then I think Mark has all of our informed consent forms. If not, you guys can reach out to me directly too, and I can get you the informed consent forms. But you want to use informed consent on peptides, ozone, PRP, A2M, exosomes, everything we talked about today, you want consent forms signed. Does anyone have any questions for me about anything? Okay, guys. Well, I appreciate everyone being on here today. I will make the slides available. I'm going to send them to Debbie,
Thank you.
and if you guys want to get it from Debbie, you can. And Debbie also has my contact information. Feel free to reach out to me directly if you have any clinical questions, have a case you're not sure what to do with. I can give you my opinion. Like I said, I love working with you guys. So, anything I can do to help you out, just let me know.
Thanks.
Thanks, boss. Thanks for
I
all
see
the
you guys.
information you always give us. I always appreciate it. I really do.
Yeah. No, thanks, guys. I appreciate it. Bye, guys.
Thank you so much.
Bye-bye.